Our next speaker is well known to everyone. He is the biggest ITP treater in China, Dr. Ming Hou, who is chief physician in the Department of Hematology in Qilu Hospital, and he's worked for many, many years in diagnostics and ITP translational research. He is co-author of the Chinese ITP guidelines. He's involved in every ITP trial in China. He's also on the revised consensus guidelines, because we're bringing in China to the revised version. So he's going to be talking to us today about drugs that are specific to China. So I think, Ming, if you're there, we're happy for you to start. We can see your screen. Thank you.
Thank you, Joe, for this kind introduction and also the kind invitation from Thomas and Joe. I'm very happy to join you again. This is my second time to attend this bogus ITP meeting. Since Sylvan, Walid, and their tutor have talked about a lot ITP new therapies, so that make my talk a lot easier. ITP, recent years, many signal transduction pathways has been disclosed, and also many potential targets and potential new drugs or new indications has been under evaluation. I will focus on these lines of drugs that come from China. So first, BTK inhibitor, Oripatinib from InnoCare has been uh, in phase 1-2 trials. The data has published in the Lancet Hematology. According to the phase 1 and phase 2 trials, two dose regimen has been chosen. One is 30 milligram per day, and the other one is 50 milligram per day. And 15 patients versus 18 patients were enrolled. And for patients in the 30 milligram arm, if they showed no response in the end of fourth week, uh, they were advised to increase the dose to 50 milligram. So 13 out of 18 patients do switched to 15 milligram arm. And the overall response is 36%. That is 12 out of 33 responded. And time to response is pretty short, 9 days. Sustained response, quite remarkable. 10 of 12 responded patients got a 6-month sustained response, that is 83%. And the safety profile is quite good. TEAEs 24%. And the most common AEs are a upper respiratory infection. And this drug is now under phase 3 study. A fixed dose of 50 milligram per day has been chosen, and 195 patients has been enrolled, and it's under follow-up. So hopefully, the end of this year, there will be preliminary results of the phase 3 studies. Very similar one, zanubrutinib from B1, also evaluated in phase 2 study. A fixed dose of 80 milligram per day has been chosen and used for 6 weeks and follow up for 24 weeks. 20 patients has been enrolled. And the overall response is 55%, 11 out of 20. And the sustained response, 7 out of 11, that is 63.6%. TAE, 25%, and the spectrum quite similar with oribrutinib. The upper respiratory tract infection is quite common. So second, SYK inhibitor, uh, sovleplenib from Hotomed has been evaluated in both 1b/2 study and also phase 3 study. In the phase 1-2 combination studies published in Lancet Hematology, uh, 100 milligram, 200 milligram, 300 milligram, 400 milligram, four dose regimen has been evaluated. And 300 milligram was considered the best one, both efficacy and safety. So in the phase 2 study, 300 milligram was chosen. And yeah, the overall response in the phase 2 study is 80%, and the sustained response 40%. The TEAEs, including LDH increase, hematuria, uh, urinary tract infection, and also hyperuremia. In the phase 3 study, also published in Lancet Hematology, uh, more patient has been enrolled, and the dose is also fixed on 300 per day for 24 weeks. For the treatment group, 126 patients enrolled, and the placebo, 62 enrolled. The primary endpoint, the 6 months sustained response rate, 48%, and time to response, 8 days. The TAE, both the frequency and the spectrum are very similar to the previous phase 2 studies. Another SYK inhibitor from China, Tianqing, uh, TQB 3473 was also evaluated for phase 1 and phase 3 study. In phase 1, those finding studies, 400 milligram, 600 milligram, and 800 milligrams, three dose has been evaluated. And in general, 600 milligram is most effective and tolerable. And the overall response for 600 milligram arm is 63%. Sustained response 33%. And TAEs 75% of the enrolled patient experienced uh, grade 1, 2 TAEs, and mostly upper respiratory tract infection and also GI symptoms. And the phase 3 study is ongoing. The dosage regimen chose is 600 milligram per day. Uh, uh, I'm not sure how many patients it has been enrolled, but uh, it's very fast. So third, CD38 monoclonal antibodies. We have one here from Aksu Bio, uh, just mentioned by Thomas, the CM 313, phase 1, very good result published in the New England Journal of Medicine. And its phase 2 also disclosed in the last EHA. Uh, Pretty good result. The phase 2 studies, 45 patients, 30 in the treatment arm and placebo, 15 cases. The overall response is 83%, although it's lower than the phase 1 95%, but it's still quite high. TTR is still 7 days. And the duration of the sustained response, the median duration, 18 weeks versus phase 1, 23 weeks in phase 1 study. TEAE, quite high, 83%. Uh, However, the TEAE mentioned in the phase 2, including infusion reactions and PTKE. I'm just curious, where are those upper respiratory tract infection, which was not mentioned in the abstract? So I'm waiting for the publication of phase 2 study in British Medical Journal. Another CD38 monoclonal antibody from Kaisi is called CID-103. Uh, Phase 1 dose finding study is ongoing, and four dose regimen has been evaluated: 150, 300, 600, and 900. I have no data showing on this study yet. Uh, Fourth, umbilical cord blood mesenchymal stem cells, which was also evaluated in phase 1 trials published in STTT, a Chinese journal. In this phase 1 study, it's a single arm, 18 patients enrolled. Three dose regimen has been chosen: 0.6, 1.0, 2.0 times 10 to the 8, 10 to the 6 per kilogram per week for 4 weeks. And 12 plus 6 patients enrolled, 18 patients enrolled. The overall response is 44.4. That is 8 out of 18 responded. The TEAE, 13 out of 18 patients showed the different TEAEs, and the SAEs, 22.2%, 4 patients, which include upper GI tract hemorrhage, profuse menstruation, and one patient with acute myocardial infarction. So that's a big concern for the safety for mesenchymal stem cells. Fifth, the BAF inhibitor. Just now, Thomas talked about ianalutamab, the Novartis BAF receptor inhibitor. We have a Chinese stuff here. It is from Suzhou, Shanghai. It's called ESG 206. Uh, Phase 1 study is ongoing, uh, and more than 10 patients has been enrolled in the study. Uh, Preliminary interim analysis data has been accepted by ASH, so the data will disclose in 2 months from now. Six, the HDAC inhibitor from Shenzhen chip screen is called chetamide. Chetamide has been also been evaluated in phase 2 trials, and two dose regimen has been chosen. One is 2.5 milligram, the other is 5 milligram, twice per week has been chosen. And more than 60 patients has been enrolled. Uh, and the treatment duration is 12 weeks. And the preliminary data has also been accepted by ASH for a poster, uh, quite similar as the BAF RA inhibitor. So two posters will be disclosed in 2 months. So that's all for my talk, and thank you.
Thank you. Thank you, Ming, for going through those. There's obviously a lot of activity in China as well as elsewhere. I'm just seeing who's got questions. I was just thinking, with all these anti-CD38s, because soon we'll have four, if they all become approved. So we have four anti-CD38s. Do we use these like TPOs? So if you fail one anti-CD38, would you then try another, or would you move on to another class of therapy? Because we use one TPO, then switch to another, then the third, before we give up. Would you use multiple anti-CD38s?
You mean use more than one in the same time?
No. I mean, if one failed, like CM313, would you then try another one, switch to another, or
Uh-huh.
would you just stop?
I suppose not. Um, the problem is those four anti-CD38 antibodies, it's quite different, the efficacy. So I can't understand why there are big difference in the efficacy, because in Walid, when he used Dara, the effective rate is only 50-60%. In the Chinese stuff, they said it's 95, and it's quite different.
Walid has a question for you.
Good to see you, Ming. We hope to
Yeah.
see you in person next year.
Yes.
And well, I have many questions, but to start with, how are we going to use all these drugs? I mean, you just introduced us to many other drugs that we haven't heard of. So how do you see the future with all these, like just PTK inhibitors? It seems like we are going to have 4 of them. And then the CD38, anti-CD38, yes. I don't understand too why the daratumumab subcutaneous is lower than the CM313, and even the Chinese dara results, one possibility is that the subcutaneous is not as effective as the intravenous. The other is probably because intravenous you give more steroids, which boost a little bit the response. And the third explanation might be also there's a difference in the pharmacokinetic, the metabolism, all these between the Asian population and the European. That's a third, as in L-Trombopac, for example. But what do you think of the possibility of finding a biomarker for anti-CD38? Are we close to find one? So the two questions: how we're going to use all these drugs, or what do you think about the future? And the second one, the biomarker CD38, anti-CD38.
Yeah, good question. Start from the second. As we have also did laboratory studies in vivo and in vitro studies on anti-CD38, and we found it's not only eradicate the CD38 positive plasma cells, but also it reduces the ability of macrophages to destroy the antibody sensitized platelet. And in addition, it also worked on immune regulatory cells. So that would be the reason for pretty higher sustained response. So, as for the indicator, predictor for the efficacy, I think maybe we can focus on the basic studies, the results from the basic studies, and find something which might be useful. But right now, I I don't know which is the best. For the first question, I have showed you a lot of new drugs, but personally, I think this BAFF receptor inhibitor is pretty good candidates because high effective rate and durable response and safety profile, especially safety profile, the infection incidence is lower than rituximab and lower than anti-CD38 antibodies. So I think BAFF inhibitor is a pretty good choice in the future. And another one, as you talked, the Syk inhibitor, fostamatinib, and the new stuff from China, the sovleplenib. I think look at the data published for phase one and phase two. It's also quite high response and durable response rate. Safety profile is also good. So BTK, I think BTK maybe not as good as the BAFF inhibitor and the Syk inhibitor. That's my opinion.
Okay, we have a question from John Semble.
Hi, Ming. It's John. Good to see you.
Hi.
Ming, I just want to go back to anti-CD38 in terms of its mechanism of action because CD38 is expressed on a lot of different cells. It has a very quick response in some of these studies. What's your view on whether or not natural killer cells are really the main target for CD38 because they seem to express a lot of this molecule?
Yeah, it's possible targeting many CD38 expression cells and NK cell. There are quite a few studies indicating that NK cell also play a role in ITP, but we have not worked on NK cells, but we can maybe we can send the students to you.
Okay, anyone, any other burning questions before we, what? Are you saying yes? You have a question? Another one? A quick one? A quick one?
Ming, another question from Walid.
Yeah.
You mentioned the BAFF receptor inhibitor, ianalumab. Don't you think it's another rituximab kind of? It's everything is similar to me to rituximab. It's just they killed the B cells. Let's see the results. This was submitted yesterday evening to one of the major journals. If it will appear, hopefully soon. But I feel very much the profile quite similar to rituximab.
Yes. I think it's little bit little bit better than rituximab. Both the overall response and the sustained response, especially the sustained response, is much better than the rituximab. And the second reason I think is quite promising is the safety profile. On our hands, when we use the standard dose rituximab, infection is real a problem. But this ianalumab, we have joined first line, second line, third line trials and enrolled quite a few patients. You know, we have a feeling that the infection, both the frequency and the severity, is mild than rituximab. Yeah.
Okay. I think that's, I think we're finished. Ming, thank you so much for your contribution. We appreciate it very much. Hopefully we will see you soon in person at, I guess some guys will see you at ASH, but otherwise, thank you again for a very lovely presentation. Thank you.
Thank you.